Oh, if everybody can please put your phones on silent, that would be great. Thank you for the reminder. Good.
Good evening. I'm Kayo, Program and Clinical Director at Cancer Support Community, Valley Ventura, Santa Barbara. And if you are here for the first time, we have been providing free of charge cancer support in this location for the last 30 plus years. And then we have support groups, mind-body classes, and educational workshops like this. And one of our support groups is multiple myeloma group. And our leader, Teresa Frank, is there. Thank you. Nice seeing you. Thank you for coming. And her group meets second Saturday of the month, 11 to 1 p.m. And including that workshop, now we have this in a May calendar, so please grab one on the way home. And a couple of announcements. We will have a National Cancer Survivors Day picnic. This is our tradition. June 1st, Saturday, 1 to 3. And then we will do butterfly release on in honor of and in memory of your loved ones with cancer. So please join us. And this Stonefire Grill barbecue is great. And on this day, Kiwanis Club, local Kiwanis Club will come and then do barbecue and free of charge picnic, so please join us. And then 2 weeks later, June 15th, we will have this inaugural Hope Walk here again, so please join us and please help us fund money so that we can continue providing free of charge support. Thank you.
All right, I'm going to give a quick introduction about the Leukemia Lymphoma Society. If you're not familiar with the organization, we focus, our mission is to cure leukemia, lymphoma, Hodgkin's disease, and myeloma, and improve the quality of life of patients and their families. So we really provide the voice of all blood cancer patients to ensure access to treatments and care. And so we do this in many different ways. It's through our research of the 40 new cancer therapies that the FDA has approved since 2017. There's been 40, and LLS has supported 34 of those. So it's really something that we are really focused on in finding those cures and better treatments for patients. We also work in public policy and advocacy to really drive cancer research funds, as well as work with the FDA in making sure that patients and caregivers have access to those therapies. And also providing the voice of blood cancer patients when there's healthcare policies that are being created. I did want to take a special focus on the arm of the organization that focuses on patients' services, the free services that we have for patients and family members. We do have our information specialists. So if you remember anything from this anything from the services that I talk about today, and you're interested, you can always reach out to our information specialists. These are master's level oncology nurses and social workers and healthcare professionals who can help you navigate all of the resources available at the Leukemia and Lymphoma Society. We have some brochures over here if you're interested, just to make it a little bit easy for you when you're at home. So we do have several different services, including a clinical trial support center where we have nurses who can help you navigate the really challenging clinical trial clinical trial world, if you've ever been on the website, it's like looking at a different language. So if you're interested in looking for what are your options, they are a great resource. We also have nutrition counseling for all cancers, actually, that you can set up a one-on-one meeting and they can help you with nutritional consultation. We have a ton of different educational materials and opportunities. This education program is one of them. We also have professional education programs online that you can experience from the comforts of your own home. We also have a podcast, so if you're stuck in traffic and you want to listen to updates on myeloma, you can listen to the podcast there. The one screen prior to, we also have a ton of free educational materials. Some of them are available here. We brought out some of the multiple myeloma books so that you can access them, and we'll send them to you for free. Lastly, the last two things, we do have financial assistance programs, everything from co-pay assistance to travel assistance to patient aid to urgent need. So they do open and close depending on the availability of the funds, but currently we have a $100 patient aid program available, as well as an urgent need program for anyone who's doing a clinical trial or is a pediatric or young adult patient. Okay. Lastly, we have peer-to-peer support, and we have this in a lot of different ways. Whether you want to talk to somebody one-on-one over the phone, we have our First Connection program. We have support groups, as well as online support like LLS Community, which is a social media platform where you can talk to each other and support each other, as well as weekly online chats that you can talk to. And they have different ones like a caregiver support online chat or lymphoma or myeloma. Lastly, we do fundraise for research, and these are the different campaigns that we have available. If you're interested in walking, doing our annual walk, or running a marathon, or you have grandchildren or children who are in school, there's a lot of different ways that you can help mobilize the mission. And we have a ton of also volunteer opportunities to help either support other patients and caregivers or to do outreach into the community. Okay? So if you have any questions, feel free to reach out to me afterwards. But without further ado, I would like to introduce our speaker, Dr. Sarah Larson, who is going to be talking on multiple myeloma. And again, if you're online, if you have questions, we'll answer them live. Just put the questions into the comment box. Okay? Dr. Larson.
Height is okay for me. I'm just going to lower this just a touch. Well, thank you so much for the opportunity to be here tonight and talk to you about multiple myeloma and the emerging therapies. There is so much going on in multiple myeloma right now, and it is such an exciting time. So being able to give these talks is such a wonderful thing for me to be able to do. Just to give you the objectives for the talk tonight, I'm going to go through with you the disease background. So we're going to give some of the framework. Whenever we have groups, we know that there are people who are at their beginning of their journey in multiple myeloma, and then people who are very experienced, who have an excess of knowledge about multiple myeloma. So we want to lay a little bit of that groundwork before we go into the current research, where we'll get into a little bit more of the science behind what's happening. With the current research, we'll first go through upfront treatment. So what are we changing when people go through their diagnosis and they get their first rounds of treatment? Then when the myeloma comes back, what are we changing with what we do for patients then? And then I'm going to talk a little bit about chimeric antigen receptors, CAR T cells, because that's something that is up and coming for multiple myeloma, and it's also something that's in the press and you may have been hearing more about outside of even your multiple myeloma appointments. So multiple myeloma is the second most common blood cancer. So the only blood cancer that's more common is non-Hodgkin lymphoma. That makes it only the 15th most common cancer. So again, blood cancers are not as common. That's part of what patients go through when they're first diagnosed. You can tell somebody, I have multiple myeloma, and there's a good chance they don't know what that means. So that's the other layer for patients, that it's important to have that education, because you're likely going to be educating your support community as well. There's about 30,000 new cases per year, but there's more and more patients with multiple myeloma because we're improving survival so quickly for these patients. And the median age of diagnosis is 69 years of age. So talking a little bit about the immune system. So when we talk about the immune system, you'll hear people talk about B cells and T cells. So when blood cells start, they start in the bone marrow. So that's within the long bones and the pelvis. Anybody who has had a bone marrow biopsy knows that there's a lot of bone marrow within the pelvis. That's why we biopsy there. Now, they start off as stem cells there. And once those stem cells start to mature and become cells of the immune system, the B cells, they go out into the blood. And when they reach their end of maturing, they actually go back into the bone marrow, and that's where plasma cells are. And so whenever you see antibodies, they're usually depicted on all of our slides as the little Ys. So at the edge of the screen there, you can see the little Y shaped, and that's antibodies. And that's because one of the main jobs of plasma cells is making antibodies. So B cells of the immune system, they mature into plasma cells. Plasma cells, when they become cancerous, that's what multiple myeloma is. And what they start doing is making all of the same antibody. So usually plasma cells, when they're healthy and normal, make all the different antibodies that your body needs to fight any kind of germs that might be around. That changes when it comes to multiple myeloma, and they only make one type. Now that one type is what we measure in your blood. So that's your M protein, that's your kappa light chain, that's your lambda light chain. That's the plasma cells that we look at in the bone marrow. So that's part of why we look at these things, and it's important to know what the cell that becomes cancerous does when it's normal, because that tells us a little bit about what it does when it becomes cancerous. So now we talk about antibodies, and we've all heard the term antibodies. People have antibodies to this, but it's important to think about this in the context of multiple myeloma, because again, that's what the M protein is that we follow in your blood, and that's also what we use to look at as far as some of the side effects that happen with multiple myeloma. We also take those antibodies that you'll usually see depicted as the Y, as I've mentioned. It's that same structure when we start talking about our immune therapies. So when we make antibodies to fight cancer, we're actually using the same structure that your body makes. So you'll see us depicted in the same way, that Y shape. Antibodies are protein. That's the protein that's made in multiple myeloma. It's also the protein that we generate when we're making our immune therapies. As most of you know, there's different types of antibodies. The heavy chain, as we call it, is A or G or D. That's usually what one of the myelomas is. And then about 20% of people only have the light chain portion of the antibody made by their myeloma, and that's either kappa or lambda. So most of you might be familiar with this as you're looking through your lab results. So when we talk about treatment for multiple myeloma, there are different phases of treatment, and it's continuous therapy for multiple myeloma. So with the exception of after CAR T cells, you always treat myeloma. So you're always on some sort of treatment unless it's for a specific discussion with you and your doctor. Now this is a good thing, because now we're looking at multiple myeloma like a chronic disease. So people do well for years and years, so that means we just keep you on therapy like we do for a lot of other diseases. We talk about things like diabetes. Again, long-term therapy for a long-term disease. The initial therapy, then a stem cell transplant, that's what ASCT stands for, consolidation and maintenance therapy, and then treatment later of relapsed disease. At the bottom, you'll see the arrow for supportive care. That's because along with what we think about as the actual myeloma treatment, we need to make sure we're doing everything we can to support bones, to support your immune system, make sure you're having the right vaccinations, make sure you're getting the right support, because as we talked about, this is a different cancer that not everybody knows about. So right now we use the term treatable but not curable. This is what we're looking to change, right? We want to change that top line, but right now this is what we call it, treatable but not curable. So patients are diagnosed. The first time they get treated, we call that frontline treatment or upfront treatment. That next response tends to be the longest, which is why we focus so much on that first line of therapy to make sure that we get people into a very good response, because we want that to last as long as possible. Then there's other lines of treatment with subsequent responses. Just because of the slide, I went up to 4, but people have many, many therapies. On some of the CAR T cell trials that I'll talk to you about, patients had up to 15 prior therapies. So we have lots of options out there for you. So again, if we want to look at that a little bit differently, because we're talking about this in each of these stages of treatment and what's emerging in the therapies, in the frontline treatment, usually people will get a 3-drug combination. I put in parentheses there RVD. Now, I don't like to be using brands when we're giving talks for education, but of course, R stands for Revlimid, V stands for Velcade, and D stands for dexamethasone. So lenalidomide, bortezomib, and dexamethasone is one of the most commonly used induction regimens. We call it induction because it induces a response. Once we get you into that good response, then we consolidate it. For a lot of patients, if they're eligible, that's with a stem cell transplant, but that is an individual patient decision. And then going on to maintenance therapy. Again, that tends to be lenalidomide, but it depends upon the discussion with the patient and their doctor. So this slide is busy, but what the important thing to note is that the regimens that we use most frequently are over here on the right, and those bars, the higher they are, the better the response rates. So the green bar is any kind of response, which is overall response, and the yellow bar is anything greater than a 90% reduction. So the really important thing to note here is that with RVD in particular that we use, 100% of patients have responded on that first trial. That's part of why we use it. That's fantastic, right? We know that people are responding. And actually the majority of them are having a greater than 90% reduction in their myeloma markers. So this is excellent. We know we're making progress up front. But we know even when we get patients into a complete response or a stringent complete response, meaning with the methods that we use traditionally, we don't detect any M protein, we don't detect any myeloma cells in the bone marrow, the myeloma still eventually comes back for the majority of patients. So why is that? We know that there are still myeloma cells there that are below our limits of detection. So with more sensitive detection methods, can we then change our treatment to bring your disease down to a lower level? The disease that's present there below what traditional methods, so things like your SPEP, which is one of the values that's probably looked at, so your M protein detection, or just looking at your bone marrow under the microscope, anything that's more sensitive to that, we call minimal residual disease, MRD. And that's one of the hot topics in multiple myeloma right now because the FDA actually approved a minimal residual disease testing assay, so a test that can be done on your bone marrow, last fall. So it is actually available to do for patients. We don't know what to do with the information clinically right now, which is why not everybody's doing it. You need a bone marrow biopsy, and we don't necessarily know how to change your treatment based on that information, but the test is there, and it's FDA approved. The reason for that is because the early studies that look at upfront patients and then did MRD testing showed that the patients that got to MRD negativity, so when we use that very sensitive test, didn't have any myeloma cells there, they had an improved survival. So we know that getting your MRD negativity can be very important in most, potentially not all, but in most myeloma patients. So that's why looking with more sensitive methods may be something that we start to do. So although it's not emerging therapy, it's one of the things that's new in myeloma and may be something that we start incorporating into standard treatment once we know how to tailor the treatment based upon the results of the tests. Now, to look at this in a picture, we can think about this as the tip of the iceberg. So if we look at the top here at diagnosis, we have a lot of myeloma cells there. We get down to the CR or the stringent CR level. Now up above, when you're at the water's surface, you don't think there's any iceberg there. You don't think that there's any myeloma cells there. But we know lingering beneath, there are myeloma cells there, and that's why eventually it will come back. So the minimal residual disease, flow is one way to test it. NGS stands for next generation sequencing, is another way to test for it, meaning if we can decrease the iceberg, decrease the number of myeloma cells there, can we essentially get to a place where we have an operational cure, which is the question mark there at the bottom. Again, this is a question, but it's one of the areas of investigation right now in multiple myeloma. So what can we do and what's being done? Because most of the data supporting the improved survival, if you can get rid of more of those myeloma cells, get to that MRD negative state, is when people are first diagnosed. So we know patients do really well with induction, consolidation with a transplant, and maintenance. But how can we improve on that? There is a medication, daratumumab. Dara is what we call it for short because that's just much easier to say than daratumumab. It's one of the FDA-approved therapies for multiple myeloma. It is an antibody. It binds to one of the markers on myeloma that's called CD38, in case you're not familiar with it. Because we know it works so well in myeloma that has relapsed and come back, we've started to look at it in the upfront setting. This trial, which we're waiting the results on, is called the Griffin trial. It took patients with multiple myeloma who had not yet been treated and then put half of them in a group where they got standard, which is RVD, the standard 3-drug regimen up front, and the other half got the standard 3-drug regimen plus DARA. And then they continued on that DARA through maintenance while the other just had the lenalidomide. We don't yet know what the results of this trial will show us, but we're thinking this could be something that could move a drug we use later in therapy up front, because we're looking at minimal residual disease testing to see, do more patients get into an MRD state when we add DARA up front? It's a well-tolerated medication. It would be a way that we could change that upfront treatment in order to get people into a better response, which we hope then would result in even more improved survival. But we don't have the results of this back yet, so hopefully the next time I come to talk to you, I'll let you know. The MAIA trial, so that was for patients who can undergo a transplant. For patients who don't undergo a transplant up front, we're also looking at DARA in that setting as well. So this study did the same thing, where half of patients had lenalidomide and dexamethasone. The other half had lenalidomide and dexamethasone plus DARA, and then they followed them through. Now, these results were updated at our annual meeting, the American Society of Hematology, in December. And what they saw is that patients in the daratumumab arm did better. So there was an improved progression-free survival, which is how long you have until you need another therapy. And patients tolerated it really well because, again, we have a lot of experience with DARA, and we know patients can do well with it. The line at the bottom is one of the important things to note because there was more MRD negativity. And if we're starting to use MRD negativity as a surrogate for survival improvement, that's part of why the higher MRD negativity for patients with DARA was found so interesting. And it's being talked about that for patients who don't undergo a stem cell transplant, that this combination, which we're calling DRD, may be what we give to patients who we choose not to give a stem cell transplant up front. So this just looks at how long it was before patients need another line of therapy. So the higher up the line is, the longer patients go before they need another treatment. The top line is the DRD. The bottom line is lenalidomide and dexamethasone. So patients who received the lenalidomide and dexamethasone, the lower line, on average, about 32 months was when patients needed to change therapies. The lenalidomide and dexamethasone wasn't working anymore. Compare that to the arm that has DARA as well, and it's not yet reached. More than half of the patients are still on treatment and haven't needed a change. So again, this is why the things up front, before we move on to relapse, so up front, the new and emerging things right now, what are we going to do with minimal residual disease testing? And are we going to start moving some of our drugs that we usually use later in therapy but are really well tolerated? Are we going to start moving them earlier on in the disease course to see if we can get to that MRD negativity? So that really takes us through the initial therapy and what we're changing there. We go on to the treatment of relapsed disease, and we know that there are a lot of treatments out there. So I'm not going to go through a lot of these, but just so that you know, there are multiple combinations out there. This is by no means an inclusive list of everything that is there, just some of the more commonly used combinations and where they are, so where their FDA approvals are. So if patients have had 1 to 3 prior lines of therapy, because that's just the way the FDA has packaged how they're approving some of these therapies. So there's several combinations there. If you've had more than 2 prior lines of therapy, there are other combinations there. It's important to note here that when we're talking about what's approved by the FDA, the induction regimen, the consolidative stem cell transplant, and any maintenance is considered 1 line of therapy. So when I tell you that some of these patients that are on clinical trials now have had 15 prior lines of therapy, you know that there's a lot out there that you can give to people, considering that upfront is considered just 1 line. So I'm going to go through with you a little bit some of those emerging therapies and what's coming down the pipeline right now. So I'll go through selinexor, which is a pill that can be taken, venetoclax, another pill. Talk a little bit about BCMA, B-cell maturation antigen, since some of the immune therapies are targeting that. and like I mentioned, specifically talk about CAR T cells. So selinexor is an interesting drug because what it does is prevent tumor suppressor proteins from leaving the cell. So there are tumor suppressors that make sure the cell stays in check, that its growth doesn't become out of control. One of the things that tumors do and what myeloma does is get those out of the nucleus, get those out of the cell. Because if they can get their regulators out, then they can do whatever they want. And so selinexor prevents that. It keeps all the regulators within the cell so that the myeloma cells can't grow. So it's interesting because this is a new mechanism of action that this drug is targeting. There was a trial called the STORM trial. This combined the pill selinexor with dexamethasone. In patients who had had multiple lines of therapy, they saw a favorable response. Now, the FDA has looked at this, and we thought it was maybe going to be approved just that combination. They've said, wait, we're not ready to approve it just based on that. They want the results of the next study, which is the Boston trial that I have listed there. They want the results of that trial, which will probably be out sometime in 2020, to determine whether or not this will be an FDA-approved drug for multiple myeloma. So right now, UCLA, as well as other institutions, have selinexor in clinical trials in combinations with drugs like DARA, as I've talked about, one of the proteasome inhibitors, carfilzomib. So we're still looking at it in multiple clinical trials, but before even some of those clinical trials read out, it may become an FDA-approved drug, so it's why it's an important drug to look at today, in addition to knowing that, yes, we have clinical trials for patients with it, it's also something that may become FDA-approved soon. Now, venetoclax is another drug that you take that signals to a pathway that usually tells the cell that it's time that the cell needs to die. Now, that's dysregulated in a lot of cancers, including multiple myeloma. So what this does is make sure the apoptotic proteins, the proteins that tell the cell to die, are working correctly. Now, this is an FDA-approved drug for lymphoma and for acute myeloid leukemia. So the good thing is we're seeing the overlap in the disease biology of the different blood cancers. So now we can take from them and say, all right, we know that those pathways are important in multiple myeloma. We have a safe FDA-approved drug in CLL and AML, so let's look at it in myeloma. Well, that doesn't always perfectly work because the FDA actually just halted all the venetoclax trials in multiple myeloma because of concerns for safety. So we are learning things about disease biology and where there's overlap, but that's why we still have to test it. So that's why you may say, oh, well, then we could try this. We don't know because patient diseases are different and they may interact differently with a medication than some of the other diagnoses. So they may open back up, but right now venetoclax trials are halted by the FDA for multiple myeloma. There's been no safety concerns otherwise for the CL and AML portions. So talking about targets for multiple myeloma. So there's lots of targets on the surface of the myeloma cells. So if you look at a myeloma cell, you can see all of these, and some of them I've already talked about, like CD38. So these are all present on the surface of the cell. So we can use them as ways for our antibodies and other cells to essentially hook on so that we can signal for the immune system to get rid of those cells. Now, we have to be careful because what we want to do is find something that's present on the myeloma cells, but not on any other cells, so that when we train the immune system to target the myeloma cells, they don't target any healthy cells. So we look through and we see all these options, and the one that's really come out as the winner for a lot of the therapies is something called B-cell maturation antigen, BCMA. And the reason for that is that it's almost exclusively present on plasma cells, and it's higher on multiple myeloma cells than it is on normal plasma cells. So it's a real win as far as a target for programming the immune system. Now, how do we do that? We know we can do it with antibodies, where they can then target something like BCMA, but how do we make an antibody better rather than just a signal for the immune system? One of the things is called a bispecific, or we call it BiTE. So these are another group of types of antibodies that are FDA approved for other diseases, and now we're starting to look at them for multiple myeloma, only targeting something different so that they hit the myeloma cells. Now what this does is it has two targets on it. That's why it's called a bispecific. The first one is against BCMA. The second one is against something that's present on T cells. So what that does is that it signals that this needs to be a cell that's killed by the immune system, and then brings the immune system in the vicinity to hopefully better help the immune system to see that, all right, this is foreign, it's tagged, we need to get rid of it, because that's what the immune system can do. So that's one of the things that's being looked at right now with BCMA is a bispecific antibody trial, and those are present across the country looking at, can we have a response for patients that's better than just an antibody if we also have something that'll bring the immune system in the close vicinity. But of course, that relies on the patient's immune system being functional. And in multiple myeloma, one of the things that happens is that the immune system is no longer functional. So if you're dealing with an immune system that's not very functional, even bringing the T cells close to the myeloma cells that have been targeted to be killed means that it might not work. So how can we get around that? How can we not rely on a decreased immune system in a myeloma patient and still have a really effective immune therapy? Well, then we need to get into the space of engineered cell therapies. And CAR T cell is a type of engineered cell therapy. So what CAR T cells do is bring together the B cell. You know, we all recognize the Y shape as the antibody, right? So you get the specificity of binding of a B cell with the killing machinery of a T cell. Because what T cells do is they see the cell and then they kill it. So how do we bring those together? We do it with a CAR T cell. So we have the antibody portion on the outside, so that will drive the cell to get to the myeloma cell. And then once it binds on, it'll signal to the T cell portion to get rid of the cell. So now you have a therapy that doesn't require the host's immune system, the patient's immune system at all. It's just all right there packaged within the T cell. So another way to look at this, so outside of the cell, you have what they will sometimes depict as SCFV, which is the single chain variable fragment. That's the antibody portion of the CAR T cell. That's on the outside of the T cell. The little line there, that's when you move to then on the bottom, which is on the inside of the T cell, and that's where all the T cell killing machinery works. So basically all this does is bind with the Y-shaped portion, signal to the inside, and gets rid of the myeloma cells. You'll hear people talk about first, second, and third generation CAR T cells. That just has to do with how many inside portions of the T cell has. So over here, the example where it has two things, CD28 and CD3 zeta, that's a second generation CAR because there's two different components on the inside of it. This is not necessarily important for what we're talking about today because everything in the clinic is using second generation CARs. But in case you hear people talk about it, and one of the things in the news is third generation CARs, at least then you know what they mean by first, second, and third generation CARs. So the CAR T cell structure, as I talked about, so this is just looking at it in more of a picture. So this is actually using the CD19 example. So this is not a myeloma example, but this is the FDA approved example because for leukemia and for lymphoma, there's a CD19 CAR T cell that's FDA approved. So you have the tumor cell, and that expresses CD19. The antibody portion, the Y portion, then binds the tumor cell and signals to the inside portion to then what you have here, proliferation, cytokines, those are killing chemicals that the T cell can release, tumor lysis, so breakdown. So that's where you can see that all that needs to happen is that this engineered T cell sees the tumor, everything is inherent, it doesn't rely on the patient's cells at all. So how do we do this? So we have to engineer the patient's T cells. Right now, we're doing it all with the patient's own T cells. So what we do is we take the patient to apheresis. So if anybody's had a stem cell transplant, you know what the hemopheresis lab looks like, right? The blood goes out, we take your stem cells, goes back in. This is the same thing, only we collect your T cells rather than your stem cells. We then take those T cells and then they're sent off to be manufactured. So we engineer them to have the CAR T cell be on them. And in the meantime, the patients watch closely because it takes about 3 to 4 weeks for this to happen. That's not how long the engineering takes, but all of the quality controls that need to happen, that's about how long it takes. During that time, the patients watch closely at home, and then they start chemotherapy in the clinic because there is a 3-day course of chemotherapy that needs to be given because we need to wipe out a lot of the cells of the immune system in order for the CAR T cells to be functional. Because if your immune cells are still there and we give the CAR T cells, it may shut down some of the CAR T cells. So we need to make sure we take care of those. So there's a little bit of chemotherapy in the clinic. Right now we're giving all of the CAR T cells in the hospital. And again, even though this sounds like a big process, it is just like a blood transfusion. It goes in over the course of about 15 minutes, just like when we do a stem cell transplant. So Why are we so excited about this? Well, we know it's FDA approved for lymphoma and leukemia, but what is it doing in multiple myeloma? Now, the construct that's the farthest in development is the anti-BCMA CAR T cell Bluebird Bio, so BB2121. Now, this took patients with a median of 7 prior lines of therapy, so these patients had been through a lot of different therapies, and they found that 85% of patients responded. Now, DARA was approved with a 30% response rate in a similar patient population. So you're seeing 85% versus 30%. So you can see that this FDA-approved medication that we like so much, we're moving up to the front line of therapy, had 30%, this has 85%. The median time until there was a need for another myeloma treatment, that's again what progression-free survival means, was about 1 year. And this is 1 year without any other therapy. So it's the one time, like I mentioned, where we don't talk about continuous therapy in multiple myeloma. That may change, but for right now, after CAR T cells, you get a full break, meaning you don't have any other therapy. You have close monitoring, but not other therapy. And they have their next round, so if they added a 7 onto it, and that's the next round of development that they're looking at to see if the CAR T cells can be around a little bit longer so that there can be a longer time before patients with myeloma need another treatment. This is going to be before the FDA, so we are hoping that this will be FDA approved somewhat soon. One of the other CAR T cells that targets BCMA is called JCAR125. This is just completing its phase 1, so that's the first time that we're looking at it. So we don't have as much efficacy data, so how well it works, but we do know that it's very safe. Very, very safe. So one of the things that's been in the news about some of the leukemia and lymphoma is that it does have a lot of side effects. At least with this construct, with the JCAR125, it actually looks like it's much safer, which is a very good thing. 7 out of the 8 patients that were reported at ASH had a response. More patients are being treated on this, and they'll likely open their next phase, so phase 2, which is the second round that clinical trials go to, sometime over the summer. So more and more patients will be treated with this one as well. So I've given you that, and we're excited about it. It's giving responses, long responses in patients who didn't have other treatment options, and long responses without having to take a therapy. But we're still not curing, right? So we still need to be looking at how can we improve on this, and how can we not have there be a 3 to 4 week wait time for people before they get their CAR T cells. So off the shelf is a concept that's being discussed and designed, meaning that you could be able to use T cells taken from a healthy donor that then could be used. Because right now it's all patients, we have to do apheresis, then we have to do 3 to 4 weeks for it to be manufactured. Now, could we have a way where we further engineer the T cells so that then we can just take a healthy donor, modify the T cells, and give them so they're ready right away for patients, so they don't have to wait those 4 weeks, potentially have to worry about the disease progressing before we can give the cells. Overcoming resistance. So just like we have a bispecific antibody, can we put 2 targets on the CAR T cell so that there's 2 antibodies on the outside so that there's less mechanisms of escape so that the myeloma can't just shut down its BCMA and then get away from the CAR T cells? That's one thing that we know that cancer cells can do, is that they can just get rid of the target that we're targeting. Well, if there's 2, it's harder for the cancer cell to do that. And then also using stem cells. So if we use stem cells, does that mean that there's a renewable source? Because your stem cells in your bone marrow continue to make cells. So if we modify stem cells instead of T cells, which is one of the things we study at UCLA, could we then have a renewable source of cells to keep fighting your myeloma without having to give subsequent infusions, subsequent chemotherapy? And actually, we're one of the institutions who have done a lot of work with stem cell modification, so we feel very comfortable with that here at UCLA. So just to give you a little bit of a picture of what that might look like for what we call an allogeneic or someone else's CAR T cell, there are different components of your T cell that say this is self versus not self. That's what we have listed there as HLA. Now, HLA is something that's important for immune system matching. It's part of allogeneic stem cell transplant. But we also have to look at it if we're going to take someone else's T cells, because we need to make sure we knock that out, because otherwise, when we take someone's T cells and give them to a myeloma patient with a CAR T cell, they would recognize normal, healthy tissues as foreign. And we don't want to do that. So we have to take that out. We also need to make their T cells not as functional, so we need to take out the T cell receptor. Well, as we have more gene editing techniques, this is actually very feasible, that we're able to take out HLA, we're able to take out the TCR, and then put in something called a universal HLA, so that then we can fully edit this T cell, so we might be able to have something off the shelf. So this is where the technology of gene editing, so CRISPR in particular, which has also been in the news a lot, can be used to then modify those T cells. Overcoming resistance, as I mentioned, antigen escape. What that means is that the cancer cell loses the target. So one of the things that could happen again with BCMA is that the myeloma cells can wise up to that there are CAR T cells that are targeting their BCMA, they turn off their BCMA. Well, if we have another target for the CAR T cell, it's harder for them to turn off two things. So we've been seeing, at least in the laboratory, that using the two targets seems to be more effective. This is just an example of a CD19, CD20 construct from one of my PhD collaborators that just shows, again, the structure is essentially the same. You just have two antibody portions outside rather than the one. So just to give you an overview of where these clinical trials are at UCLA, because of course that's where I am, so that's where I can offer clinical trials to patients. So we've mentioned most of these. Some of them are not yet open, including, I will point out just the CAR T cell trials, which is the cell gene one, the bottom in the middle, as well as the Juno trial. So those are going to be open again sometime probably within the next several weeks for the Celgene Bluebird Bio trial, and sometime over the summer for the JCAR, which are probably going to be two of the more exciting trials that are out there right now for patients with multiple myeloma who have had multiple lines of therapy. And again, I'm happy to provide this list with the clinical trial numbers. So clinicaltrials.gov, it is a foreign language, like LLS has already said to us, but I can give you at least the clinical trial numbers if you're interested in looking up any of them. So in conclusion, there has been incredible progress in the treatment of multiple myeloma, and patients who previously didn't have therapeutic options really have a new hope with everything that I've talked about today. And so we're really excited about some of these therapies in development, and I'm excited to be able to have that slide say curable and not just treatable, but not curable. One of my connections with Leukemia and Lymphoma Society is Climb to Cure. So team and training had been mentioned. Climb to Cure was started by one of my patients, and this is a picture on the side there of her and I in the inaugural hike at the top of Mount Kilimanjaro in January of 2017. So she raised $1 million for Leukemia and Lymphoma Society in the first year she was able to start this. So you can accomplish whatever you want after you get through your treatment and those most difficult first points. So really using this as an inspiration, and I feel like that's what stories like this do. And that's just a picture of Kilimanjaro, which is really incredible and very intimidating once you get to the base of it, I have to say. So I just want to thank you, and we'll open up for questions now.
All right, so we are going to be taking questions from obviously the audience here as well as those that are online. But please, if anyone has a question right now, please go ahead.
When you were talking about the different lines of therapy,
Mm-hmm.
if you were on a particular therapy that worked for 2 or 3 years and then you relapsed and you changed your therapy, does it necessarily mean that the drug you were on that worked for 3 years could not be reintroduced later as another line of therapy in combination with other drugs?
So that's an excellent question, and I'll just repeat it so everybody can hear it well since I have a microphone. The question is, if there was a therapy that was working for 2 or 3 years, then therapies were changed, and the question was, could you revisit the previous therapy potentially in another combination? The answer is yes, and multiple myeloma changes along the disease course. So each patient's multiple myeloma is different at the first treatment, the next treatment, the following treatment. There are little changes. So if something has worked well in the past and a patient has tolerated it in the past, it is very reasonable to then revisit it potentially in a different combination.
We have a question online. Is a low platelet count part of the disease?
So a low platelet count, so platelets, the cells that the body uses to clot, that can be part of the disease. The multiple myeloma cells are in the bone marrow, so any of the blood cells, their production can be decreased. The classic is a decrease in the red blood cells, the hemoglobin, but the platelets can also be affected.
If you're in treatment and you go out of remission, does the body build up an immunity to the treatment you were on?
So the question is that if you are on a treatment and it starts to become active again, does that mean your body has built up an immunity to the treatment that you're on? What that usually means is that your multiple myeloma has found a way to get around that treatment. And that's why it's time to say, all right, we have a lot of options out there. What do we do differently? Is it a completely new combination, or is it using something we've used previously in a different combination? But yes, once it starts to come up, it's not necessarily that you're immune to it, but that your myeloma cells now know how to get around that specific therapy.
Okay. We have a very specific question online. So if a patient's heavy chain has responded well to a GSK antibody conjugate trial, and her M-spike has gone to 0 and normal IgG, but has shown an increase in her lambda due to a light chain lump found in her sinus and pelvis beyond the radiation treatment, what other course of action would you recommend? Did that make sense?
So that sounds like a very specific patient condition. So, any time that there's still active disease is a time probably to look for other therapy. Again, it's hard to know for each individual patient, and that's where you'd really sit down and take a look at all of the information. There can sometimes be parts of the myeloma that responds and other parts that don't. And so it may be that the heavy chain, say the IgG has gone down, but the lambda may have gone up. That just means that some of the myeloma characteristics are changing and that myeloma may need a different therapy.
Okay.
I think there's another question.
Yeah, I'm on the first line treatment right now. And just curious, am I going to stay on the rest of my life just with the Revlimid? Or are these CAR T programs and therapies that they're developing, is that going to enable me to get off the fence?
That is an excellent question. I don't know the answer to it yet. Right now, patients stay on lenalidomide for as long as they tolerate it, and it's controlling their myeloma. Are we going to get better at our engineered cell therapies and see better outcomes? And say, all those patients that we have on lenalidomide, we have something better for them so they don't have to be on therapy? Potentially. I think only time will tell. But that's part of why it's an exciting time. Yeah.
Question. So theoretically, can CAR T cell therapy be used in combination with immunomodulatory drugs?
That is another excellent question, and likely one that will be answered in clinical trials, because that's, of course, one of the first things that people think about. How can we improve the efficacy as well as persistence? And the first thing, especially that you look at in multiple myeloma, is immunomodulatory agents, which means lenalidomide, pomalidomide, for right now.
Gotcha. Any other questions here?
Yeah, there's one in the back.
Stop it. So I've got the dexamethasone and a steroid working with it in an infusion, but I'm sort of a little discouraged. It seems like if you don't take Revlimid, maybe you're not getting very far.
So the question is, if you can't take Revlimid, so lenalidomide in that class of drugs, is that going to be a difficulty in the treatment of myeloma? You are definitely not alone in difficulty in taking lenalidomide. It can be really hard to take. People can have low blood counts. They can have rashes, severe allergic reactions. So that happens for people. We just have to give different combinations for you.
Well, so far it hasn't been done, so I'm just wondering. I'm going to bring this up.
Okay.
I do go to UCLA.
Okay.
With all the things on
Right. So we usually would say that we wouldn't give the MMR vaccine because it's live attenuated to myeloma patients. Some of us are rethinking that in the current outbreak. So if patients are greater than 1 year from their stem cell transplant, have good immunity, I am checking their measles titers and vaccinating them if they are negative. Now that is solely my practice because there's not one guideline on this because we haven't had a measles outbreak in a long time to this degree.
Mm-hmm.
So.
Any other questions? Oh, go ahead.
I was diagnosed when I was 43, and I've always asked Dr. Black, Dr.
Oh, yeah.
Do I need to get revaccinated? I've always heard from different people, well, you should get revaccinated because I was the stem cell candidate. I did my stem cell transplant in the 6th floor.
Mm-hmm.
And that always, and with the measles, the spread of measles, it kind of bothers me because then there's measles, there's chickenpox, just the different diseases that are out there.
Right.
It's like, should I get vaccinated again? They're telling me no. Which I trust them, they saved my life, so I trust my life with them.
Yeah.
But there's always in the back of your mind thinking, should I protect myself?
And that's where it really does become a patient-physician discussion about what's the risk-benefit. And the risk-benefit has shifted a little bit now with the presence of measles, and so it's a continued discussion. They may want to check your titers because actually, just from my experience, a lot of patients have kept their titers, so kept their antibody, kept their immunity against measles. So in a way, it's just reassuring them that we see that.
So one question, what is the minimum GFR count needed to do a CAR T treatment?
So the GFR, that's the kidney function. So it varies from trial to trial. So it would have to be trial specific as far as what they require. The Bluebird bioconstruct trials right now require a GFR greater than 45. But again, it's always trial specific.
Okay. Anyone else? Oh, go ahead.
If you've had the measles when you were a child,
Mm-hmm.
and I haven't had a stem cell transplant, would I have to be vaccinated, or am I still?
And again, most people who have had it will retain their immunity. But again, I'm not an infectious disease doctor, so I don't want to be speaking too much out of turn as far as, what the recommendations should be for each patient. But I think just checking titers is a very basic thing that you can do that can give you some reassurance one way or another. So that's what I've been doing with my patients.
All right. If there are no other questions, let's give a warm round of applause for Dr. Larson.
Thank you so much.
Thank you, everybody, for joining us here today. If you are interested in any of our other Closer to a Cure community lecture series, everything is published online, and you can just go on the UCLA website for that. We do have evaluations available to you. If you would please fill those out. They're really, really helpful for both the Leukemia and Lymphoma Society and the cancer support community to continue on doing programs like this for free, and to let us know your thoughts. Other than that, we have, I think, still food available and some resources available for you as well, and we're obviously here for questions. So thank you very much.